All right, I think we'll get started. Good afternoon. It's my pleasure to introduce our grand round speaker for the day, Dr. Don Dengel, who is professor in the School of Kinesiology and also an adjunct faculty member here in our own Department of Pediatrics. Dr. Dengel completed his undergraduate degree at the University of Wisconsin-La Crosse, and then went on to Ball State for a master's degree, and then on to the University of Georgia for a PhD in exercise and applied physiology. After that, he did a postdoctoral fellowship at the University of Maryland, and then spent some time at the University of Michigan on the faculty before joining the University of Minnesota as an assistant professor in the School of Kinesiology in 2000. Dr. Dengel is a fellow of the American Heart Association and a fellow of the American College of Sports Medicine. He has published approximately 100 peer-reviewed publications. He's an active teacher in the School of Kinesiology. In fact, he, over the last few years, has developed a really unique course about pediatric physiology for the kinesiology students, which I have had the pleasure of lecturing in, as well as some of the other faculty members from our department. He's also an active mentor, has a bunch of PhD students and master's students that continually come through his lab. He is the director of the Human Performance and Densitometry Services for the Clinical and Translational Science Institute here. That's the fancy title for he is the Exercise, Vascular, and DEXA guy in the CTSI. So if you use any of those services, you probably know Don. One of the challenges that we face for those of us that do pediatric preventive medicine is that we are relegated essentially to using surrogate measures for hard clinical outcomes. So in other words, it's very difficult, in fact impossible really, to do any type of preventive medicine intervention study instituted in childhood and then follow those kids on into adulthood to see who has an MI or who develops type 2 diabetes. And so really we are relegated to using non-invasive methods of, in this case, artery health as endpoints in our studies, and also to characterize, for example, a normal weight child versus an obese child and try to describe the health of the arteries. And so when Don joined the faculty in 2000, he set up a really state-of-the-art non-invasive vascular laboratory that measures all sorts of things that he's going to cover today. And it really has a theme of pediatrics. Although he has done some adult studies, I would say the lion's share have been pediatric studies. And so he's been an active investigator and collaborator with many faculty members in our Department of Pediatrics. I should say, before I have him come up, is that Don was my PhD mentor, so I know him very well. And since that time has been an invaluable collaborator to me and a friend. So without further ado, Dr. Dengel.
Thank you. It's a pleasure being here. Aaron asked me to if I'd come and give a pediatric grand rounds, and he says, you've been here for how long and you've never spoken to the group? He says, I don't even know if you're an adjunct professor, and I don't think many people know that. So it's a pleasure to be here. I don't have anything to disclose. I'm just a college professor. I don't have any great investments in any great drug companies, nor do I know any great investments to give you today. So stock tips are out today. You'll have to figure those out. Like Aaron said, I came here in 2000. I came from the University of Michigan. I was actually in gerontology. And I was interested in the blood flow and the relationship between metabolism and basically insulin and how it affected flow. And when I came here, I had 2 willing pediatric participants in my household who became subject 1 and subject 2. And so people always ask, how do you know what age to do vascular FMD studies on? How'd you ever figure that out? Subject 1, subject 2. Okay? 2 years apart. If the 4-year-old could do it, we were okay. If the 2-year-old couldn't do it, nobody was going to do it. My pediatric subjects now are adolescents in high school. So through that period, we've grown tremendously, not only in my own household, but in how we look at metabolism and its link to the peripheral vascular system. So today, really what I want to talk to you about is a few things. One of them is just to kind of give you a little bit about the vascular system, describe ways that we can measure the vascular system, talk about different pediatric populations who have vascular dysfunction, and ways that we can maybe improve vascular function in these populations, and then what's the future look like as far as measuring peripheral vascular function and actually trying some newer things. I always like to have a fun fact because they're always good at cocktail parties. So the one thing is if you take all the blood vessels in your body, link them all around, put them together, they'll actually circle the globe twice. So that's approximately 60,000 miles. So I love when people say, what's the value of looking at blood vessels? I say, twice around the Earth, there's a lot of value in that. Inside the blood vessels, though, we always thought they were just conduits, carrying blood, taking away waste products. We now know, obviously, that inside there are some very specialized cells called the endothelial cells. And they basically are inside of every vascular system on the arterial side of things. They do many different things now that we know besides just allow blood to move. They're involved in regulating blood flow. They're involved in muscle contraction as far as being able to change themselves. And also they're very receptive to different types of CO2, oxygen, lactate. They're very responsive, and they move the vessels with that change in those different components. Now, the trick is how to measure that. Like I said, in an adult population, it's pretty easy. We put in some art lines. We start infusing the drugs we want. We can look at how that vessel changes over the course of the different drugs we prescribe. It's fairly easy. That doesn't work very well when you try to take that to an IRB and say, I want to do it in an 8-year-old or a 10-year-old. And most parents aren't really kind of very anxious to say, yes, you can put an art line in my child and infuse 4 substances that I've never heard of before. So the trick is, how can we develop things to look at this in children? And there are a few things out there on the market. Some of them you've heard of. One is the EndoPat, which is sort of a digit system. It looks at the flow volume in the fingers, and basically you create reactive hyperemia with a cuff, release that cuff, and then measure the flow change in the finger. The bad side is it was designed for adults, and it was designed for an adult finger. So it doesn't do very well in pediatric populations. There's the Sigma Core, which is a pulse wave device where we look at the different pulse waves. So we send basically a signal through the body and capture it at another end somewhere along the way, whether we go from the radial side or the femoral side or the carotid side. We look at how that pulse changes over time. It does well in very large studies. It doesn't really show us much in very small studies. So we're kind of left with one thing, ultrasound imaging. Most of you are probably familiar with ultrasound imaging for its use in looking at carotid IMT. And although that's great in older populations or very diseased populations, most children have carotid thicknesses that are relatively small and in a very normal range. But there's other things we can do with the ultrasound. And one of those systems that has been developed is basically challenging the blood vessels and then watching their response. And that's what we call basically flow-mediated dilation. And to do that, we create some occlusion with an automated cuff system. We pump it up to about 200 millimeters for about 5 minutes. And then we release that. And as we release it, the blood starts to move down the vessel wall. And as it does that, it creates a lot of flow disturbance against the endothelium. That creates NO release, and then we get dilation. How well the vessel dilates is really a great indication of its overall health. Now, we've done a couple things here where we actually kind of trigger it so that we get it at the same cycle at the cardiac, so we're always looking at the same diameters. In addition to that, we've developed a very nice computer tracking system. So we save our technician hours and hours of time, although he still spends hours of time. It basically, once it learns the artery wall, it can start to track it. And it will do it from beat to beat. So what we get is we get this very nice flow curve. And you can see right here is the vessel as it's being occluded. We release the cuff. And in most people, you get this sort of constriction of the vessel, and then this huge increase in the diameter of the vessel. It's this increase, this flow-mediated dilation, that is an indicator of health. And we'll talk about this little piece a little later as we get going. Now, as I said, we're very interested in aging. Some of the very early studies looked at FMD or flow-mediated dilation or infusion studies. And obviously, there's a decline in vascular function with age. And you can actually see this is males here, normotensive, and this is normotensive females. And you can obviously see there's a big change once we get into postmenopause years. Now, because it's an aging-associated disease, the first thing most people look at is, what are the things that create abnormal function in the vessel? And the likely culprits obviously are going to be diabetes, smoking, LDLs that are very high, hypertension, and these create a lot of dysfunction in the vessel itself. Now, those are really a lot of characteristics of an adult population. We don't have a lot of 6 or 7-year-olds with smoking. We don't have a lot of them with very large hypertensive populations. So the question then sort of in your mind is, why do we want to study vascular function in a pediatric population? It's probably more likely that most of the diseases that we're going to see here occur really in young adulthood or later on. But some of the very first studies by Cellumar, who kind of developed the ultrasound imaging technique back in '92, looked at children that had genetic predisposition for hypercholesteremia and found that they had flow-mediated dilation that was much lower, as you can see here in the red bar, compared to the control population. And then Cellumar, and we've done this too in our lab, also wanted to look at the other contributor to the vascular system. So we know that the inside has this nice layer of endothelial cells. Around the outside is a smooth muscle cylinder that's holding everything together. So Cellumar wanted to actually look at that. So we had to come up with something that would pass through the endothelial cell and go right to the smooth muscle. So what he used was nitroglycerin. So if you give nitroglycerin, it will pass through the endothelial cells, go right to the smooth muscle of the artery, and then cause dilation. And you can see it's a lot significantly larger dilation than is brought about by the endothelial cells. So Cellumar also found that those children also had smooth muscle dysfunction. And for a long time, we've been measuring both endothelial-dependent dilation and endothelial-independent dilation, or nitroglycerin-mediated, based on those early Cellumar studies. Now, since then, people have really started to look at other things. This is a very study in children looking at type 1 diabetics. Again, you can see here's flow-mediated dilation, significantly lower than their matched control group, although, like we said, their IMT is the same. So this is a population, a pediatric population, that has endothelial dysfunction as well. We can also look at cystic fibrosis, which is a newer group that people are starting to look at. Again, here's a control group of children. Here's our cystic fibrosis children. And again, they have flow-mediated dilation that's much lower, which would be indicative of some type of vascular dysfunction related to that disease. Now, we had a different group that we were interested in studying. Obviously, obesity, as many of you know here in the pediatric population, is increasing not only US-wide but worldwide. So we were very interested in kind of examining how does obesity really affect vascular function in children. And one of the very early studies was by Tunen, and he took children that were obese above the 95th percentile, so these are very obese children, and compared them to normal weights. And what Tunen found in this very early study was that not only was flow-mediated dilation, endothelial dependent, as depicted here by the red bar, much lower than the normal weight children, but again, they had this smooth muscle, or endothelial independent dilation, that was also much lower than their normal weight counterparts. So that led Tunen and others to hypothesize that morbidly or very obese children had endothelial dysfunction as well as smooth muscle dysfunction. Well, we were very interested in that as well. So we started a study and we decided, let's move down. Let's not take that level of obesity. Let's come down to the 85th percentile. And let's see if we actually start to see dysfunction in this group of 10-year-olds. And again, we matched them for age, we matched them for gender. And what we found, similar to what Tunin found in the overweight, morbidly overweight group, was that in these overweight children, again, vascular function measured by flow-mediated dilation was significantly lower. In addition, this group also had the smooth muscle dysfunction as well. So they were showing signs both of endothelial-dependent dilation dysfunction and endothelial-independent dilation dysfunction. So the smooth muscle cells as well as the muscular artery wall were also dysfunctional in this group of overweight children. Now, the one thing that we have an advantage is that we can actually look at the flow curves instead of single points. And early studies just use one point in time to look at. We developed a system where we could actually measure the flow over a period of time. And what you see is again, you see that very high flow-mediated dilation in our normal weight population. But you also see that it's not only lower at one single point, but all along their flow curve, you see a much reduced vascular presence. So when they're challenged with that hyperemia effect, they not only can't reach the peak point, but they're always lower across that whole flow curve. So then people kind of said, well, let's start looking at other issues. And obviously Minnesota is really what I think one of the great cancer centers in the United States. And there was a very good population to look at of cancer survivors. And this is some data from Julia Steinberg's study where we've looked at endothelial function in healthy childhood survivors. So they're all under the age of 18 here. And again, we have a control group. We have a group that has leukemia, another group that has CNS, and then another group that has solid tumors. And again, we measured vascular function, just flow-mediated dilation in this group. And you can see that in this group, although there has a tendency for the other groups to be lower, it's really the leukemia children. These are the survivors of leukemia that have a much reduced vascular system. Now, if you look at their IMT up here, you can see that as far as the IMT, the groups are the same. So we're starting to see the vascular dysfunction start first before we start to see a structural change as far as measured by an IMT in this group. Now, there are also things that we started to look at using the ultrasound imaging besides IMT. So we also realized that we could start to look at fluid mechanics of the carotid artery. As the ultrasound started to advance and they started to have more clip storage space, we can actually take little clip movies and then look at the carotid and see how it responds to a normal situation. So what we sort of do in these places is we're really looking at two functional measures of the carotid. We're looking at compliance, which is really a measurement of that organ, the carotid artery, basically to recoil to its original diameter. So we're measuring the blood pressure. At the same time, we're measuring this flow change in diameter. And then we can also look at the distensibility. And this, again, is really looking at that artery's ability to stretch both during systole, return back to diastole, and using that as a sign of atherosclerosis. Now, the reason that we sort of started to look at this in addition to our flow-mediated studies is we can do this very simple. In addition to that, flow-mediated dilation studies are extremely difficult. Unless you have an excellent technician, which I have, these studies are very complicated. They read very easy, but they're very difficult to do. And they're more difficult to do in children. But the carotid studies are very easy to teach sonographers around the country how to do because they're very used to doing IMT studies. So we just have to basically teach them how to keep a clip store of that and measure the blood pressure. So that system has really sort of allowed us to look at things too. And we did the same kind of studies that we did in Julia's population with flow-mediated dilation. We also did our carotid studies looking at compliance and distensibility. And again, what we see is this pattern developing. Here's our leukemia children right here. Here's our CNS. Here's our solid tumor. And here's our control group. Now, you want to have more distensibility. The more distensible the artery, the better it is. The more compliant the artery is, the healthier it is. So the greater value is what we want to see. Again, you see these leukemia survivors having very low cross-sectional distensibility. And similarly, again, we see them having very low compliance cross-sectionally as well. So the disease is affecting not only the brachial artery where our flow studies are done, but it's more of a systemic issue that we can look at and see it's actually happening in the carotid artery as well. Now we've also started to look at some other groups, and this is some of Aaron's data that he's captured using some MPS 1 and 2, and we actually have done this in conjunction with California CHOP Hospital. And again, teaching their sonographers how to use our system, how to send us their clip stores saved, and then we can reanalyze it. We've noticed that here's a control group, here's our MPS 1 and 2. You can see a significant decline in compliance. So again, the artery isn't functioning to its maximal capacity. But unlike the other children studies, our MPS children have extensive thickening of the carotid artery. So they not only have an issue with the function of their carotid artery, they actually have some structural issues that are going on in that carotid artery as well. But because of the development of this technique, we can look at these very small genetic populations and include multi-sites by training them this technique. So it's a little bit easier to manipulate and use than the flow-mediated dilation studies. Now, the second question is, so you found some vascular dysfunction in children. Can you do something about that? We always want to try to make improvements in that. How can we make improvements in their vascular function? And that really led us to the early studies. You can see this is Aaron, as you said, a young PhD, full of a lot of really good ideas, wanted to do a lot of things. He said, I want to do a training study in children. I said, you're crazy. No one does a PhD doing a training study unless they are suicidal. But Aaron convinced me that this was a good idea. And so Aaron set off on taking obese children who had never exercised and putting them through an 8-week exercise program, 4 times a week, 40 minutes. So spent a lot of time in the lab with these kids. And I can remember Aaron coming into my office times going, you got to talk to subject number 2. I just can't take this kid anymore. So I did come out once in a while in my office to talk to him, but Aaron did most of the work. What we see here is we had 2 groups. We had a control group and we had an exercise group. Again, we're looking at flow-mediated dilation, pre-intervention, post-intervention. You can kind of see here is our pre-intervention, the exercise group in the yellow. We use yellow for the pre in the control group, and red is the post-intervention. So after 8 weeks of exercise, what happened to our children? The control group, you can kind of see, they didn't get worse, but there's definitely no improvement, and they're sliding a little bit downward. This was a study done in the summertime. Our exercise group that did our 8 weeks, you can see there's a significant improvement in not only the peak, but the whole curve elevates and stays upward longer. So a movement up the curve upward, not just in a single time point, but along the entire curve, which to us was very significant. It showed that in children, we could take those children that had low vascular function, and we could use something like exercise, a very simple thing, and implement that and see an improvement. Children have a very significant adaptability from their vascular side when it comes to this. Now, what's really interesting is we took the data then and we looked at it a couple different ways. We put our normal weight children and put their flow curve up. We looked at our overweight children before their exercise program, obviously much lower than the normal weight. We already showed you that. But what's interesting is after the 8 weeks of exercise, here's our kids again. And you can see that they go up and they attain the same vascular function that the normal weight children did. There's no weight loss here. Our kids remained exactly the same weight through that 8-week program. Little known, exercise really isn't a great weight loss tool. Great physical activity tool, but not a great weight loss tool, especially when there's an ice cream shop just across from my lab. So we didn't have any weight loss, but you can see this improvement. What that shows us is that in children, we can bring the vascular function back to a normal level. You don't see this in adults. Adults will get improvements with exercise, but they can't get back to a normal value. They can just improve themselves. So in children, you have a window where you can bring them back to where they were previously. Now, if we kind of look at some studies by other people, Wu did a study in 2004, and this is sort of the piece that becomes significant. He did an exercise training study in overweight children just like us, 6 weeks, a little shorter, sees a significant improvement in endothelial-dependent dilation. Then he takes his children and he tells them to stop exercising. And after a year, he comes back and he measures their vascular function again. And what he finds is that it declines, starting to decline over time. Now, if they would have continued training like his other group, they'll maintain that vascular function that they saw an improvement with in that program of 6 weeks in length. So the take-home message is here is that, yes, exercise is very good at making an improvement in vascular function. But if you don't continue it, you're going to slide back to where you were. Even if you're a child and you're overall healthy, you have to maintain that physical activity. The blood vessels really enjoy that surging motion that exercise produces and has that flow disturbing on the walls. It enjoys that. Take it away, and it will return back to where it was. So it's important when we talk about these things to realize that this shift is a temporary shift. It can be lost just as easily as we gain it. Now, not every overweight child is going to exercise, as Aaron found out. So let's try something else. Let's try weight loss. So we brought about a program that was basically 12 weeks in length, a little longer for us this time. It was the Shape Down program, which was developed in San Francisco to work with overweight children. And we had two groups, a control group and an overweight group. You can see here's our control group. Over that 12-week period, you see a significant increase in their weight. So obviously, as children over 12 weeks, if you're overweight and you're eating, you're going to continue to gain weight. Here's our exercise group. They basically lost about 3 kilos of weight. Doesn't sound like a lot, but when your counterpart is gaining about 7 kilos of weight, you're actually doing a pretty good job in this group. You can see that the percent fat for our weight loss group drops basically about 3%, where the control group stays relatively the same. But what's more important is we start to see a change in endothelial-dependent dilation. Not significant, probably due to a low end, but you can see the increase in the endothelial function in that 12-week weight loss program. Control group remain relatively simple or stable. If we look at independent dilation, you see a significant increase in that smooth muscle aspect of vascular function. So again, the control group dipping down but relatively remaining the same. So weight loss, like exercise, can create some vascular improvements. It's not as powerful, in my opinion, as exercise, but it still can accomplish some vascular changes that are needed. Now, people say, well, what's the future hold in this? One of the things we want to do is we're not just satisfied with measuring peripheral vascular function. It gets a little old for us. So we wanted to go to cerebral vascular function. And this actually came from some of my colleagues in neurophysiology who saw a lecture I gave on vascular function and said, that is really cool stuff. I wish you could do that in the brain. And they said, but you have a small problem. That cuff that you're using to create that disturbance or that challenge, I don't know how you're going to do that. So I went home, tried it on my wife. I agree. Bad way to do this, okay? She said it was not very fun, and she wasn't going to do it again. So we had to come up with something else that we can challenge the vascular system in the brain to. And what we found was manipulation of PCO2 and PO2. The brain is very receptive to that. Now, a lot of times people say, well, you can just hyperventilate and you can do that. Well, in a magnet, when you're hyperventilating an MRI, your head starts to move. And that's bad, the MRI people tell me, when you're trying to look at images. In addition to that, when we hyperventilate, we're not only changing PCO2, we're changing PO2. So the dynamics is very difficult to control in that environment. Fortunately, when my colleagues challenged me to figure it out, we did a lot of reading. We found that there were some people in Canada that had started to develop a system where they could manipulate the PCO2 inside the MRI, but maintain the PO2 at a constant level using sort of a specially developed mask and basically a very sophisticated sensor that made really quick adjustments in the gas that the individual was breathing. And so using that, we sort of try to develop a challenge that we wanted to look at. And what we came up with was basically what we call the square wave ramp challenge. And what we did was, this was the goal of our PCO2. So we first of all just tried to create a 10 millimeter change in the PCO2 in the individual. By manipulating the gas, we elevate his PCO2 10 millimeters but keep his PO2 the same. And we do that over 2 sequences that we can measure in the MRI. Then we want to take the person, we want to see how far can you go from the bottom to the top of your range in PCO2 in your brain. So what we do is we take the individual, we take their PCO2 and we drive it all the way down to 30. The normal's about 40. And then we elevate them all the way up to 50. Now people go, oh, wow, that's terrible. No, it's what we actually see normally if we get on planes, if we exercise, we see these gas changes constantly. It's just not as controlled as we do in here. And here you can see this green is the sequence that we try to put out as far as what we want our PCO2 to be. The blue is actually the measured PCO2 during our test. And the red is what we call the bold signal, or the spinning of the oxygen label inside the brain, which is what we use to measure flow changes in the brain. And you can see how quickly, when we change the PCO2, the brain's dilation capacity changes in response to that. And when we drop it off and bring it back to normal, the brain responds just as quickly. And then when we basically drive it down, the brain goes with it. And when we go up, the brain changes as well. So the system is highly sensitive to the manipulation and allows us to look at the vasculature in the brain. And so, wanted to know how reproducible is that. We did a series of day 1, day 2 tests in 12 different subjects and found that we can reproduce this fairly accurately from day to day. And we can actually do it within a day. We actually have studies where we did same day, 2 studies separated by a half hour. So the first thing we decided to do was people talk about the damage that chemotherapy can do. And we know from our leukemia patients that they had vascular dysfunction in the periphery. So we wanted to do a case study where we took one survivor of leukemia and matched it with a female control. And you can see they're pretty well matched as far as age, weight, percent fat. Our survivor was diagnosed with ALL at 2 years of age. These are all the medications that she underwent during her procedure. And what we found is we used sort of a triple wave in the very early things, but you can see that this kind of bold signal change is significantly lower. I shouldn't say significantly, we only have an N of 2 here, is much lower. It doesn't seem like a lot, but the MRI people tell me in bold signal terms, that's a lot of change, is much lower in that individual. What's also interesting, we decided to do some neurocognitive testing. And what we found in some of our neurocognitive studies is that our ALL survivor had trouble with verbal memory tasks. She was much slower on those tasks. She also had difficulty in concentration. So the idea is the damage in the peripheral that's possibly caused by the leukemia linked to some of her neurocognitive issues? So we were fortunate enough to get a grant from Hyundai on Wheels, Hope on Wheels, and basically we're measuring cerebral vascular function in leukemia survivors and looking at neurocognition to see if these two link up. Is the damage that we see in peripheral vascular function some going to show up as a result in neurocognition? We also were very interested in concussions. Isn't everybody interested in concussions? So on this campus, in an exercise physiology lab, very easy to find patients with multiple concussions. So we decided, let's do some pilot work again and see what we have. So we had someone who had no concussions, which is, on this campus, is hard to find someone who hasn't had a concussion. We had an individual who had 4 sports-related concussions, and we had an individual who had 7 sports-related concussions. And what we found is looking at using that same sort of changing the PCO2, measuring the bold signal, looking at what we see with the additions of concussions, less and less vascular reactivity. Again, almost like the flow studies, these individuals, as they suffer more and more concussions, their blood vessels react less and less to the stimuli. In this case, it's altering the PCO2. So it took us 2 tries to convince the NFL that this was something they wanted to look at, but we're now looking at this multiple sports-related in cerebral vascular function with a grant from the NFL. And so hopefully we'll have some data for the NFL, although they already settled their lawsuit, so I think they're safe for a while from us. But we're not going to give up on ultrasound imaging. Yes, we're kind of exploring this new system to us, but we haven't given up on our old favorite here. And really, Aaron has a grant where we're looking at really circulating endothelial cells and microparticles in youth and looking at more mechanistic peaks at the vascular system, at the vascular dysfunction in children across lean to morbidly obese, and looking at how these endothelial cells and these other markers are playing into this role. In addition, I showed you that very early symbol where we said, you know, when you first do a flow-mediated study and you release the cuff, the first thing that happens, and all my students raise their hand, is the blood vessel dilates. And you say, no, actually it's the opposite. It constricts itself and then it dilates. We haven't been able to really look at this because we haven't had the technology to capture that much information. But now with our newer systems of imaging, we're able to actually get a hold of this very early piece. So this is where you have students who come in with those ideas and they say, I think that little dip means something, you should look at that. I said, that's a really good idea. I've got 2,000 vascular studies that you should look at and figure out what that means for me. So we're going to actually start looking at what does that effect mean. When your vessel starts to constrict right away, does that indicate some further health of our vessel? I just talked to Joe, my technician. He says, you know, we had the PAD people, and they never do the Bernoulli effect. The really little kids do it a lot. So maybe there's some information in there that will allow us to look at vascular health and see another piece of the vascular puzzle for us. And then we're very interested in medications. Not every kid's going to exercise. Not every kid's going to go to a weight loss program. We are going to have to figure out other ways to look at vascular health and try to improve it. So a couple of things that we want to look at is we want to look at TNF-alpha blockers in vascular function and MPS patients. We know that MPS patients have vascular dysfunction from some of the studies we're doing with Aaron and our friends in California. We know that they're starting to use TNF blockers. We want to see, does that make an improvement in vascular function? In addition, we also want to look at what do our old reliable friend statins do in cancer survivors. We know that the leukemia survivor is demonstrating vascular dysfunction, not only in the periphery, but also in the cerebral vascular. What if we go about trying to treat that very early on after their chemotherapy regimens have been completed? Can we make improvements through these type of medications? So we're always interested in looking at those pieces. And before I kind of conclude, I want to say, you look at all these studies, you see one guy with a pointer in his hand telling you all these things you do. You have to realize how many people it takes to pull off these studies. We wouldn't be anywhere without Joe Harmon. He's the person who is with every little kid, putting that ultrasound on the neck or on the arm, telling them it's a great test, everything's going to be fine. So without Joe, we don't have this great database we have. We have to thank Julia and Alan, Dan Maroney, Joe for all the studies we're going, and of course Aaron and all the graduate students that come through my lab that learn vascular function and come up with the new idea that then we go and we try to carry out. So with that, I want to thank you for having me here. Next time we'll get into more details, but I just wanted to give you an overview of what we're doing to try to look at some of the pediatric things.
I'm guessing, if you didn't talk about it, I got here a little late, then it's nitric oxide release that's causing the vascular activity. Have you tried to block it or reproduce that data by giving sildenafil or Revatio? Or whatever?
People have, in adult studies, they've done the block studies. So those have been done. We haven't done them in children. Again, you're really going to be very limited in what you want to do in children to figure it out. We know that the endothelial vascular system is dependent on the NO and the shear stress that's created. And we know that when we exercise, we create tremendous amounts of shear stress and we can get improvements. And some of the studies in humans have demonstrated that NO effect that's very positive. So that's a really big piece of the puzzle, you're right.
One other question. You talk about the Bernoulli effect. What about the Coanda effect? Children with Auber AS tend to have higher blood pressure in their right arm. Have you looked at that vascularity compared to the left arm and see if there's any difference?
People have looked at arm studies, and what the favorite one is usually tennis players. So you get a tennis player, you look at their dominant arm, which is their tennis arm, you look at their non-dominant arm, and yes, the vascular function is different. In the tennis arm that uses the racket, the vascular function is usually much higher. In the non-dominant arm or non-tennis swinging arm, it's usually different. So you have to realize vascular function is sort of this dependent variable that moves, but if you really do, and people have done a number of hand grip studies where they just do tons of hand grip and they'll look at the vascular function, you can make a localized improvement in a vascular bed if you really focus on it and give it a lot of significant, shall we say, turbulent flow, which physical activity is increasing turbulent flow. There's physical activity is a huge piece of the vascular system. So in every population where you kind of have a suspect idea that they are less physically active, you're probably going to see the vascular system be kind of compromised a little bit. But in these groups, when you kind of look at them compared to other groups, the controls that aren't very physical activity, and you match for that, they still have a mechanistic problem that's attacking the vascular system. So, for instance, in leukemia patients, it's most likely not the cancer that's the problem. It's the chemotherapy agents that we're using to treat the cancer that's the problem. In the obese individual, it's not so much the fat, but it's what the fat is really starting to stimulate, and that can be the adipokines, the inflammatory process. We know that inflammatory agents push the vascular system in a very significant way in a decline. So anything that's going to create inflammation, any disease state that increases those inflammatory products is going to push the vascular dysfunction that we see. So the common thread, I guess if we want to pick on one, is really about inflammation. Any disease that has some type of inflammatory process in it is going to push hard on the vascular system. And that's why you kind of look at, well, you know, high lipid levels, if we can lower that with statins, TNF-alpha blockers. Can we look at things that decrease that inflammatory side of the equation?
Have you looked at different types of exercise? Does it matter walking versus running versus weightlifting? Is there a difference in how?
We've looked at, in adults, we've looked at weight training. We can get significant improvements in weight training. I don't think I've seen a swimming study. There have been a lot of, Aaron's study was actually a biking study. So people always kind of go, you're doing biking, but you look at the arm, why don't you look at the leg? I mean, that's the one that's working. But you can see that it's really a systemic effect that really takes place when we exercise. people, I'm trying to think of other studies as far that I've looked at as far as alternate physical activity. It's mostly been really, it's a very big systemic effect. It's probably, but you do have these kind of unique cases where we have the tennis player, where we have a localized effect, or the one-arm hand grip versus the non-hand grip side. You do see that change. So it has a local, but it also has a systemic aspect to it. Claudia.
Are there many studies that look at the role of stress on vascular function? Can chronic stress or even acute stress change it? So you can see it?
I'm not aware of any ones that have looked at where we can kind of increase a mental stressor and look at the vascular function.
Comparing kids who have been chronically stressed compared to those who haven't.
No, I haven't seen any studies. Most of them have been some sort of disease.
Have you looked at studies with food?
Oh, yeah. Boy, have we ever looked at food. Yeah. Yeah, I left that one out. So we had this really great idea that sugar is a bad substance. It's in pop and it's on TV. And there have been a number of studies that when you give people high glucose loads, their vascular function goes down. So we thought, beautiful, we're going to put a hole in the pop industry by giving kids these big glucose loads. And we're going to look at obese kids, we're going to look at lean kids, and we're going to show them that when you give them these huge glucose loads like we see in adults, their vascular function will go down, therefore pop is bad for you. So we did this study, and lo and behold, didn't do anything. Didn't matter if you were lean, didn't matter if you were obese. I could give you this gigantic sugar load, and it would not change your vascular function. And people said, oh, why does that happen? I think one thing we have to remember is that when you're a child, your vascular system is extremely healthy. It can really take some horrific abuse. As we get older and the vascular starts to harden and calcify, it does not take abuse that well. So we've done how many Big Macs can I eat and measure my vascular function? How many Krispy Kreme donuts can I eat and measure my vascular function? That's always the grad students love that one. So it's really, in children, they can take a lot of forms of very bad diets, and their vascular system can really, acutely, can handle it. Now, chronically, if I were to give you sugar drinks over a long period of time, I think you're going to start to see it wear on the vascular system. But that acute administration of one single bout of a high-fat meal, of a high-sugar meal, doesn't really affect it in children. It can in adults, though.
What about the pediatric populations that are already challenged, and we give them something that is productive in assisting the vascular system, like green vegetables, or what the American Cancer Society says is helpful to the body? What about the reverse, not looking for the bad, looking for good?
We've done the grape juice, done the tea. Those are all done in adults. We didn't do those in kids. I think the grape juice didn't. Did the grape juice do anything? No, grape juice didn't do anything.
Phytonutrients require that you put them all together. You put combinations of food together in order to.
Right. I think that, and one of the things we found, if you look at the literature, there's been a lot of high-fat meals. And then when people come back to try to reproduce, so the first really great vascular study, they fed them the breakfast meal from McDonald's. And they found that when they ate that, their vascular function went down. So people decided to replicate that by giving them basically fat milkshakes. And what they found is they couldn't reproduce it. So a lot of people have come up with the theory in some of the fat meals is that it's not fat so much, it has to be cooked and processed that really creates the problem for the vascular system. Creating uncooked fat won't really affect it, but once we go through that cooking process, it does alter what the vascular system can do to it. So there are some studies like that, but not done except for us in the glucose one. There aren't that many in children. I think someone had a question. No?
I have a question. What are the clinical implications of all these tests? So, whenever we submit a paper, we always get the question, so FMD, what is a normal percent dilation for a kid? And then we show in a paper that it's, different by 2 percentage units, and then we always get the question, well, what does that mean? Is that within the normal range still? Can you talk a little bit about that, folks that think that way?
Yeah, I mean, and that's a great question because we talk and we do all these tests. People say, what does it really mean when the day is done? What do you get out of all that information? I think, and we're doing a collaborative study with our friends in Liverpool, and we're combining all of our vascular data in children so we can make a normative table so we can say 6 is bad, 4 is worse, 2 is really bad, and 8 is wonderful. But I think what we see is when we start to see that vascular dysfunction, the alarming thing should be to somebody is that we're already starting to see huge compromises in the vascular system. If go unchecked, they are going to lead to the cardiovascular events that we're going to see later on in life. The beautiful thing about a child, especially before the age of puberty, is you have a real brief point in time where you can go in there, intervene, and improve the vascular system, and there's really very little damage done. If you start waiting until after puberty and then successive years, the damage is going to be constant, and it's not going to be able to erase it. We can make an improvement, but like we saw in Aaron's study, you're not going to get it where the curve goes right back to normal. You're going to get a curve that comes and is a little bit reduced. And the longer and longer you wait to intervene, the more reduction it's going to be. So the clinical implications is it allows you to take a glimpse and see what's going on. As far as the leukemia patients, we know that this hospital, other hospitals around the United States are very good, up around 80% as far as the survival rate in leukemia patients. That's not the problem so much anymore. It's the post-young adult years where we're starting to see this advent of very early cardiovascular diseases. And so the issue is now we can see this starts very early in that process of their disease. Almost immediately after they complete their chemotherapy, their vascular system is compromised. And again, it's like we talk about with the children. There's this brief window. We can make an improvement and maybe get that vascular system back up. But if we don't, they're going to be on a very fast train to cardiovascular disease and all the implications that go along with that. So I think that's what we're seeing. The early identification is key, but then you need to act on that early identification. So. Yeah. Who's got them? Let's see. I don't really, you think about the longitudinal. Yeah. Yes, the Finns are probably the best at the longitudinal. They have the young Finn study, and they've been tracking not so much flow-mediated dilation. They're more carotid IMT. So they've been tracking IMT. They've just lately added the flow-mediated studies into their population, but now their young Finn study is more like a young adult study versus kids. So, yeah, longitudinal work is necessary. The problem with longitudinal work is try to convince NIH that, yes, fund me for 5 years, and then how about a renewal for me to bring these kids back in and study them again? There's not much interest in that as far as NIH is concerned. They're very interested in this, but a longitudinal study, there's not a government interest to fund it, and these are expensive things to do, unfortunately. So I'd love to have a great answer and say we're going to, but unless we see some real reform in NIH, I don't think we're going to see what longitudinally a lot of this means. Unless we can get some young American studies like the Finns have being funded over in Europe, we can probably see these things. Little soapbox there for anyone. Right, your congressman? Thank you.